Hello. Today our topic is endodontic disinfection and obturation. So as you all know, endodontic disinfection and obturation is critical for the complexity of the root canal system, as there is a lot of the presence of spins and anastomoses, and therefore the cleaning of the root canal becomes extremely difficult. So our objective is to remove all the pulpal and dentinal debris from the root canal system. And for this biomechanical preparation, along with chemo-mechanical debridement is extremely important. So once you do preparation with mechanical instruments like your hand instruments or your rotary instruments, that is mechanical shaping of the canal. And we definitely need to use chemical disinfectants along with it. Now, these disinfectants, they can be in the form of irrigating solutions, chelating solutions, and intracanal medicaments. So first we'll discuss what are the ideal properties of the irrigating solution. So they should possess broad antimicrobial spectra. That is, they should be effective against aerobic and anaerobic microorganisms. They should dissolve the necrotic pulp tissue. They should inactivate the endotoxins which are produced by the microorganisms, prevent the formation of smear layer, and in case it is formed, then they should be able to dissolve it. And they should be systemically non-toxic, non-caustic. Now, what is smear layer? Smear layer basically is a layer which is produced of inorganic and organic debris. And this is because when you have mechanical cutting, maybe because of the burr or the rotary instruments, that this kind of layer is produced. So inorganic component basically is your hydroxyapatite crystals. Organic is your microorganisms, the pulp tissue. So the functions of the irrigants are as follows: antimicrobial action, flushing action so that the debris is flushed out of the canal system, dissolution of necrotic and vital tissues, lubrication and removal of the smear layer. Now, to classify the irrigating solutions, a very easy classification was given by Dr. Kandaswamy and Dr. Venkatesh Babu, and this was in 2010 that this classification came. So we have endodontic irrigants, and broadly they are classified into chemical agents and the natural agents. So in the natural agents, you have antibacterial agents, which is like your green tea, triphala, and in the chemical agents, they are further subdivided into tissue dissolving agents, antibacterial agents, and chelating agents. Now, tissue dissolving agents, you have mostly sodium hypochlorite. Antibacterial, it can be bacteriostatic or bactericidal. Bactericidal is which kills the microorganism. Bacteriostatic is it does not let them to reproduce, right? It will arrest the reproduction process, so the copies are not replicated. So bactericidal mainly is your chlorhexidine. Bacteriostatic is MTAD. Chelating agents, they are basically for the inorganic component of the smear layer. And in this, we have having mild pH and strong pH. So in case of mild pH, HEBP, and in case of strong pH, we have EDTA. Now, the gold standard of irrigation is sodium hypochlorite, which is a strong oxidizing agent. It is a clear straw-colored liquid, and it is the 5% of free available chlorine is available, and mostly commercially it is available as Clorox. Now, the efficacy of sodium hypochlorite has been found from the concentration of 0.5 to 5.25. And there has been literature showing that there is no difference in the antimicrobial efficacy if 5.25%, 2.5%, and 1% of sodium hypochlorite have been used. And also, if the lower concentrations of sodium hypochlorite is used, then you can actually increase the action by using larger volumes, frequent change of the irrigating solution, and by longer time of exposure. So what is the ideal volume of irrigant that should be used? So according to the literature, it has been found that per tooth, 5 ml of the volume is adequate, and up to 3 ml of sodium hypochlorite of 5.25% is sufficient to cause effective debridement with antimicrobial action. Now, coming on to the antimicrobial efficacy, I told you that 0.5 to 5.25% is the range. And in this, we have found that even 1% sodium hypochlorite is able to kill the bacterial spores for a period when it is kept for a period of 30 minutes. So 1 and 5% sodium hypochlorite, they are also effective against Candida albicans, which is a fungus. Now, what is the time which is required for the antimicrobial effect to take place? Now, there are two conditions. One is when the smeller is present, which is the presence of smeller. In that, it will take longer time, so it is 1 hour. And one is when the smeller is removed. So when you remove the smeller, 5% sodium hypochlorite, for the complete antimicrobial action to take place, it takes 5 minutes. So what is the mechanism of action of sodium hypochlorite? So basically it has germicidal mechanism of action. Now this germicidal action is mainly because of the formation of hypochlorous acid. So this acid, it permeates the cell wall and combines with the protoplasm. This dissolves the necrotic tissue, and there are basically three steps which are taking place. One is saponification, next is amino acid neutralization, and third is chloramination reaction. So these three, they actually sum up the mechanism of action of sodium hypochlorite. So saponification is basically soap formation, right? So the sodium hypochlorite will act on the fatty acids and it will form soap and glycerol. Whereas in case of amino acid neutralization, that is basically when it is acting on the proteins. So the amino acids, they will produce hydroxyl ions, which will lead to the change in the pH. And then we have chloramination reaction. When the hypochlorous acid is formed, it reacts with the amino acids and it leads to the formation of chloramines and water. Now we come to the chelating agents. So chelating agents, we have basically EDTA, which is the disodium salt of ethylene diamine tetraacetic acid. And it was first discovered by Nigard and Ospai in 1957. Now this is also used in, for the disinfection and as an adjunct in the root canal disinfection. And this is insoluble, odorless, and crystalline powder, which is available. It has a pH of 8.3. And this is mainly, it deals with the inorganic component of the smear layer. So for the organic component, for the necrotic tissue, for the microorganisms, for the pulp tissue, it is basically your sodium hypochlorite which takes the lead. And for the inorganic component, which is the dentinal debris, the hydroxyapatite crystals, they are basically the chelating agents which will act upon them. So functions of EDTA are mainly twofold, that is the lubrication and the removal of the smear layer. And EDTA, it is available in two forms, that is viscous and aqueous forms. So the aqueous form is used as the final flush after shaping and cleaning for the smear layer removal. The viscous form, it also aids in dissolving the smear layer, but besides that, it also acts as a lubricant. So there are also other irrigating solutions which are available in the market like tetracyclines. So there are three types like tetracycline hydrochloride, minocycline, doxycycline. As you all know, this is antibiotic and therefore they have a broad spectrum of action. And so they are also used for as irrigating solutions in endo. Now we have chlorhexidine, which is another cationic bisbiguanide, and it possesses antimicrobial action. This is mainly from the pH of 5.5 to 7. So as you can see in this diagram, you have chlorhexidine, which is positively charged. They go and attack the negatively charged phosphate group on the microbial cell wall. So this cell wall of the microbes, it possesses phosphate groups, which are negatively charged. So the positive charge is attracted to the bacteria or the microorganisms' negative charge, and then that causes the cell membrane lysis. Okay, so the leakage of the adenosine triphosphate nucleic acid takes place, and ultimately the cell lysis takes place. So they kind of destroy the microorganism by dissolving their cell wall. Okay. So now, which are the concentrations of chlorhexidine which are used mainly for the endodontic disinfection? So we have three main concentrations, that is 0.12%, 0.2, and 2%. So 0.12%, that is mainly used in your oral, mouthwashes. And we have it possesses a broad spectrum of action, again, gram-positive, gram-negative bacteria, fungus, bacterial spores, lipophilic virus, and dermatophytes. Now, what are the difference between spores and microorganisms? Spores are very difficult to kill because they have an extracellular polymeric matrix which is there and which makes it very difficult for the antimicrobial agents to enter the cell wall of the microorganism. So it is a protective covering. So spores are even difficult to kill as when you compare it to a viable microorganism, and they lie dormant in the body. Once the immunity is lowered, then they start activating themselves, right? So we have high concentration of sodium hypochlorite, that is 2%. That is bactericidal. So the chlorhexidine penetrates the cell wall, causes precipitation or coagulation of cytoplasm, and this acts by cross-linking. This occurs by cross-linking. Then in the lower concentration, that is 0.2%, it is bacteriostatic. So the positively charged molecules of chlorhexidine binds readily to the negatively charged cell wall, mainly to the phosphate group and carboxyl in the proteins. It interferes with the membrane transport, initializing a leakage of low molecular weight substances. Now, tissue dissolution property, as we discussed, for sodium hypochlorite, it is very high. Here, but in chlorhexidine, this is a disadvantage that it does not possess any tissue dissolvent property. And as far as the toxicity is concerned, it is, there is an absence of toxicity which is caused by by chlorhexidine. Now, next is calcium hydroxide. Calcium hydroxide, as you all know, is an intracanal medicament. Now, what is intracanal medicament basically? So when we give, suppose I have opened a tooth, I have made an access opening, now I have done cleaning and shaping, and I feel that the canal is not free of exudate, or the canal still is infected, patient is not completely asymptomatic, then I give a dressing of calcium hydroxide so that the remaining microorganisms in the canal, the remaining infection in the canal is taken care of with my adding calcium hydroxide as intracanal medicament inside the root canal. So then this will be followed with a temporary dressing. I'm not finishing the endodontic treatment or the root canal in one sitting. It will take multiple sittings, maybe 2 sittings, 3 sittings, but I'm putting calcium hydroxide medicament inside my root canal. Okay, so that is taking additional care of your microorganisms which are present after the mechanical shaping of your root canal. So this was introduced by Herman in 1920. It is white, odorless powder. The pH ranges from 12.5 to 12.8. It is low solubility in water, and it is classified as a strong base, and the action is due to the release of hydroxyl ions in aqueous medium. Highly oxidant-free radicals that show extreme reactivity, and it reacts with several biomolecules. Now, the mechanism of action is damage to the cytoplasmic membrane, protein denaturation, and damage to the bacterial DNA. So that is how the sodium hydroxide actually reacts. So hydroxyl ions mainly, they cause an alkaline pH. Okay, because of them, the alkaline pH is produced. And as you know, the bacteria, they require acidic pH to flourish, to survive. So in case of an alkaline pH, they automatically are destroyed. But there are now literature showing that calcium hydroxide, most of the microorganisms have become resistant to calcium hydroxide. So a lot of combinations of calcium hydroxide with chlorhexidine, 2% chlorhexidine gel, metronidazole gel, and other herbal medications are also used as intracanal medicaments nowadays. Next irrigating solution is ozonated water. This was given by Nabayoshi et al. In 2004, and they observed the ozonated water has similar activity, similar antimicrobial efficacy as 2.5% sodium hypochlorite during irrigation. It is a powerful antimicrobial agent against bacteria, fungi, protozoa, and viruses. So ozone is available in 2 forms. One is aqueous and the other one is gaseous phase, and it has strong oxidizing power with reliable microbial effects. Ozone destroys the cell walls and cytoplasmic membrane of the bacteria and the fungi. Increased permeability leads to ingress of ozone, which causes microbial death. So cell lysis again takes place because of the cell membrane permeability, which is caused by ozone. Next is MTAD. Now, MTAD has tetracycline. It is a mixture, okay? It has 3 things. That is, it is a mixture of tetracycline, acid is the citric acid, and detergent, which is 2-in-80. Now, what does a detergent do? It reduces the surface tension. So once the surface tension is reduced, the irrigant is able to actually penetrate through the dentin easily. So it is able to enter to the microorganisms easily. It can cause dissolution, okay? It is able to go into the dentinal tubules easily. because the surface tension is reduced. Citric acid, as you know, it will also remove the smear layer, plus it is bactericidal. Tetracycline is an antibiotic. It is a broad spectrum antibiotic and a calcium chelator. Plus, it has substantivity activity. So the substantivity, again, as I earlier mentioned, that the release of your antibiotic will take place till further, for some more days, not just on the day of application, but at least from some days till 4 weeks, right? So MTAD and smear layer. Although MTAD removes most of the smear layer, remnants of the organic components are scattered on the root canal wall. Effectiveness is enhanced when lower concentrations of sodium hypochlorite are used as intracanal irrigant before the use of MTAD as final rinse. And this is like sodium hypochlorite in a percentage of 1.3 concentration. Now, the antimicrobial effect of MTAD appears to be more effective than 5.25% sodium hypochlorite in disinfecting root canals after the removal of the smear layer. Now, coming to Ruddle solution, you can have a short note on sodium hypochlorite. Ruddle solution is also extremely important as a short note question. Irrigating solutions and their classification or ideal requirements can come as a long question. So all these questions are extremely important. So Ruddle solution is basically a radio opaque irrigating solution. Okay, so radio opaque is because you have this Hypec M radio opaque high contrast injectable dye, which is injected, and this can be visualized in the X-rays. So the composition is 5% sodium hypochlorite, Hypec M, 17% EDTA. It has a solvent action and radio opacity is similar to Gutta-Percha. So you can visualize it on the radiographs. The penetration is because the tensioactive agent decreases the surface tension besides removing the smear layer. Now, there have been some recent advances in case of endodontic disinfection, like the antibacterial nanoparticles. So nanoparticles are basically everything into 10 raised to power minus 9, right? So that is like metallic nanoparticles of titanium, gold, silver, copper, zinc. They have been used incorporated as antimicrobial agents. So the electrostatic interaction between negatively charged bacterial cells and positively charged nanoparticles, accumulation of increased number of nanoparticles on the cell membrane of the bacteria have been associated with loss of membrane permeability and unsuitable membrane function. So they are able to kill the bacteria by that. Now there is also photodynamic therapy. These are all recent advancements. In case you get something, you can at least write from this. So it's photodynamic. Photo means light, right? So it will have a photosensitizer. So it is a two-step procedure that involves the application of photosensitizer followed by light illumination of the sensitized tissue, which will generate a toxic photochemistry on target cells, leading to killing of microorganisms. There is also, see here, so you have a phosphorescence which is taking place, and this will actually cause cellular death by membrane damage. So this is because there is light activation, and because of the light, because of the photo, okay, photo is light. So the dynamics takes place, and this leads to, you are actually injecting the crown, the tooth with a photosensitizer, okay? And this illuminates your sensitized tissue and it leads to membrane damage, and therefore the bacteria or the microorganisms are killed. Now, photon-induced photoacoustic streaming. This is the photoacoustic is when the laser light falls, okay? The laser impulses of subablative energies create successive shock waves, leading to formation of a powerful streaming of the antibacterial fluid located inside the canal with no temperature rising. So only good thing is that there is no temperature rising, so the normal tissue is not damaged. And there are a lot of, the laser impulses when it reaches the pulp tissue, there are successive shock waves which are there. So then what happens, the bacteria, it gets killed because of the antimicrobial action. Then there is gentle wave irrigation. Now, gentle wave is when you have broad spectrum of sound waves which are produced and they lead to endodontic disinfection. So this was about endodontic disinfection. Now we come to the obturation topic. Okay. So obturation is to obturate the canal. Okay. Once your canal is cleaned and shaped properly, the root canal, then it is time to fill and seal it. So how do you fill and seal it? That is with the help of a root canal sealer and a core filling material. So the objectives of obturation, endodontic obturation, is to prevent percolation of exudate into the root canal, prevent reinfection, and create a favorable biological environment for the process of tissue healing to take place. Now, criteria of obturation. Criteria means when will you obturate the tooth? Obviously, when the patient is asymptomatic, when there is no anaerobic or foul odor from the canal. Foul odor means there is presence of anaerobic bacteria in the canal, right? So if there is, then you will not obturate. Then when the canal is dry, there is no exudate which is coming out of the canal. There is no sinus tract which is present. And when the temporary filling is intact, and when you get a negative culture from the root canal. So negative culture means there is no bacteria or virus or fungus or microorganism which is present in the canal, right? Now, what are the requirements for an ideal root canal filling material? So it should be easily introduced in the canal, seal canal laterally and apically. Laterally means your lateral canals and your accessory canals should also be sealed. Dimensionally, it should be stable, resistant to moisture, bacteriostatic, or at least should not encourage bacterial growth, radio opaque so that you can visualize it in the radiographs, non-staining to the tooth structure, non-irritating, sterile or easily sterilized, removed easily from the canal if required. In case you require a retreatment, it should be easily removable from the root canal. Now, most importantly, what we use as a root canal filling material is gutta percha, right? So gutta percha is derived from two words. One is gutta, means gum, and percha means the name of the tree. Now, this comes from a Sapodilla family, which was Brazilian tree palanquin. This is basically extract. It is a coagulated extract which is derived from the plants of Brazilian tree, palanquin. Now, in India, these trees, they are found in Assam and Western Ghats. Now, the chemistry of gutta percha is that its molecular chemistry is close to natural rubber, and which is also cis isomer of polyisoprene. Composition of gutta percha was given by Friedman et al. And they said that matrix, which is organic matrix, it mostly composes of gutta percha, which is 20%. Filler is inorganic filler, which is zinc oxide, 66%. Radiopacifier, which is heavy metal sulfates, 11%, and plasticizers, 3%. Now, phases of gutta percha, there are three main phases of gutta percha. One is alpha, beta, and gamma. Alpha phase is basically, it is the phase in which the gutta percha is, naturally derived from the tree. So it is runny, tacky, and sticky. It has lower viscosity and pliable and tacky at 56 to 64%. This concentration, this alpha phase of gutta percha is basically used for thermoplasticized obturation techniques. Then we come to beta forms. Beta is what we get as commercially available gutta percha cones. So this is solid, compactable, and elongatable. It has higher viscosity. And gamma form is not used because it is an unstable form, right? So in case of heat-treated gutta percha, where you need thermoplasticized, you require alpha form of gutta percha. Normally, the cones which we get are beta form. Now, what are the currently available forms of GP? They are available as solid core gutta percha points, standardized and non-standardized, thermomechanical compatible gutta percha, thermoplasticized gutta percha like solid core systems injectable form. Medicated gutta perchas are also available these days like chlorhexidine acetate containing, iodoform containing, calcium hydroxide containing. So according to Cohen, he gave a classification of obturation with semi-solid material gutta percha. Lateral condensation, vertical condensation, sectional method, vertical condensation with warm gutta percha, chlorperca method, gutta percha euperca method, thermomechanical condensation method, thermoplasticized gutta percha, which is injection molded method, pastes, hydron, a hydrophilic plastic root canal filling material, pressure syringe injection technique, and nitrogen and related pastes. Now, according to Cohen, Obturation with a solid material can be with silver cones and stainless steel points. Canal obturation with rigid cones can also take place like chromium cobalt implant points. Now, recent advancements in obturation techniques include thermoplastic injection techniques, carrier-based gutta-percha techniques, thermomechanical compaction, and microseal technique. Now we come to lateral condensation, which is lateral compaction of the GP, and this is mostly used for root canal obturation. It involves placing tapered gutta-percha cones in the canal and then compacting them under pressure against the canal walls using a spreader. A canal should have continuously tapered shape with a dentin apical stop before it is ready to be used by this method. So as you can see here, see, what you have to do is first you have to select the size of your master cone. So whatever is the size of your master apical file will be the size of your master cone. It should be 0.5 mm short of the working length. So following the canal preparation, select the master gutta-percha cone whose diameter is in consistence with the largest file used in the canal up to the working length. Check the fit of the cone radiographically. If found satisfactory, place it in sodium hypochlorite for disinfection. Now, suppose if it is fitting properly, it is fine. But it can be short or it can be, extruding out. So if it is short, then you have to see the canal and do the biomechanical preparation again. Maybe there is a blockage, there are any kind of ledges which have been created. So you need to treat that accordingly. If it is going beyond the 4 mm, then there are two options. One is to cut the GP, or you have to use a bigger size, larger number cone, which should be used, right? Now select the size of the spreader to be used for lateral compaction of that tooth. It should reach 1 to 2 mm of the true working length. So we have put the master cone inside. Now we are choosing the spreader. So this is a 40 size cone. So we now go to 35 size spreader and we see that whether it is going 1 to 2 mm of the true working length. Dry the canal and apply sealer. Now, pre-measured cone is coated with sealer and placed in the canal. After master cone placement, spreader is placed in the canal alongside the cone. Just see, it is placed just alongside the cone. The master cone has been placed with the sealer. Now you are placing the cone, the spreader just laterally to the main cone. Now this spreader that will, create space for your next accessory cones to come. So after master cone placement, spreader is placed into the canal alongside the cone. Spreader helps in compaction of the GP, first thing. Second, it also creates space for your accessory cones to come. So after placement, spreader is removed from the canal by rotating back and forth. This compacts the gutta-percha and a space gets created lateral to the master cone. An accessory cone is placed in this space. The above procedure is repeated until the spreader can no longer penetrate beyond the cervical line. So how will you know that your obturation is now complete? So you keep on putting these spreaders, with lesser sizes, and the space they create, you put in accessory cones. So once the accessory cones, they stop going beyond the cervical line, your spreader is no longer going beyond the cervical line of the tooth. That means the obturation is complete. No more accessory cones will come now, and your obturation is done. So lateral condensation, the name has been given lateral compaction. Why? Because spreaders are put laterally to the master cone. These spreaders, they compact your master cone, the GP, and then they create space for your accessory cones to be put in, right? So that is laterally, they are compacting your gutta-percha. Advantages, they can be used in most clinical situations. During compaction of GP, it provides length control, thereby controlling overfilling. Disadvantages, in case you have a lot of accessory or lateral canals, it will not flow into that, right? So does not produce homogeneous mass, may not fill the canal irregularities efficiently, and spaces may exist between accessory and master cones. Now, next we have vertical compaction technique. Vertical, as the name suggests, it is not laterally to the master cone, it is on top of it. Vertically, you are compacting it. So, isme what we do is like we have the main advantage of this method is that it will seal your lateral and accessory canals. Okay, so here Schilder was the one who actually gave this technique, and we have Schilder's, the heated pluggers which we are using for compacting the GP vertically. They are Schilder's pluggers which are used. So technique is master cone are selected and fit short of the prepared working length. They more closely replicate the prepared canal. Here you can see, right? Heated pluggers or spreaders are used to apply heat to the master cone and remove the excess coronal material. So heated pluggers you will be using vertically and you will remove the excess coronal material. And then room temperature plugger is used to compact the heated GP. So heated pluggers say you have actually removed the extra GP, the coronal part of the GP, and with a colder plugger, with a room temperature plugger, you are trying to condense the GP which is inside the canal. And then you will apply apical compaction, and a guttapercha segment is placed in the canal and heat is again applied. The process is repeated for the coronal portion of the canal by placing and heating a segment of guttapercha, and that is how you fill the coronal segment as well. Now, because you are putting vertical pressure, the main disadvantage of this method is that, one is that it can extrude, okay, out of the canal because you're putting a lot of vertical pressure, plus vertical root fracture can result because of the high pressure you are putting during compacting. Advantages that it is excellent sealing of of canal apically and laterally, so that the lateral and the accessory canals they are sealed. Disadvantage: increased risk of root fracture, overfilling of canals with guttapercha or sealer from the apex, and it is time consuming. Now next we come to continuous wave of condensation technique. Continuous, as the name suggests, that the heat is continuously applied, right? Here what we were doing, we were condensing it with a heated plugger. We were cutting it with a heated plugger and condensing it with a cold room temperature plugger. Okay, here what we do is that the same plugger, okay, which is heated, and the machines used can be touch and heat system, Endotech 2. So the heated plugger device is actually put in, coronal GP is removed, and the same heated tip, okay, you'll just switch it off so that there is no heat being supplied now. Put it there for 10 seconds, put the pressure there for a minute, and then you again heat it and then remove it. So the same continuous heat is being applied to the GP. So this technique provides the clinician with the ability to employ length control while incorporating a warm guttapercha technique. So there is length control also. The use of warm vertical compaction, lateral compaction with the Endotech demonstrated an increased weight of guttapercha mass by 14.63% when compared with traditional lateral compaction. So this is basically continuous wave will not have vertical pressure. The GPs are condensed laterally. Technique: select the plugger which matches the selected guttapercha cone. See, place rubber stopper on the plugger so that the length control is there, and this should be 5 to 7 mm short of the working length. Confirm the fit of the GP. Dry the canal, cut the GP half mm short and apply sealer in the canal. So half mm short of the working length, you have cut the GP, you have applied sealer. On the plugger, you have actually marked 5 to 7 mm from short of the working length and put the stopper. With the system B turned on to use, place it in touch mode, set the temperature to 200 degrees Celsius and dial the power setting to 10. Cut the cone at the orifice with preheated plugger. With the preheated plugger, you will cut the cone at the orifice. Push the plugger smoothly through the guttapercha to 3 to 4 mm of the binding point. Now release the switch. Held the plugger here for 10 seconds. You are still holding it, but you have released the switch. So no longer heat is being applied, no longer the 200 degrees Celsius temperature is being reached. 10 seconds, you'll keep it there, sustain pressure to take away any shrinkage which might occur upon cooling of the GP. Maintaining the apical pressure, activate the heat switch for 1 second. Now you're still applying the apical pressure, but you will activate again for a second, and then you will remove the plug. Okay, so you have first applied heat 200 degrees Celsius, put pressure on the plugger, cut the plugger, and now you are switching off the device, keeping your plugger there for 10 seconds, pressuring it, trying to compensate for the shrinkage which is there on cooling. And again for 1 second, you will apply heat and then remove the plugger. After removal of plugger, introduce a small flexible end of another plugger with pressure to confirm that apical mass of guttapercha has not dislodged, has cooled and set. Now, advantages of system B is it creates single wave of heating and compacting. Thereby, compaction of filling material can be same time when it has been heat softened. Excellent apical control, less technique sensitive, fast, easy and predictable. Thorough condensation of main canal and lateral canals. Compaction of obturation material occurs at all levels simultaneously. So Endotech 2 is three-dimensional obturation of the canal is achieved, better sealing of the accessory and the lateral canals, and it is used to soften or remove the GP at the same time. Now we have other systems like thermoplastic injection techniques. This is like heating of gutta percha outside the tooth and injecting the material into the canal. So this was given in 1977 at the Harvard Institute. It consists of a unit, electronic unit with pistol grip. See, like a pistol, it has a grip syringe and specially designed gutta percha pellets. So pellets are there, which are put into the machine, and then with the piston, the melted GP is injected into the canal. So technique is, before starting the obturation, the applicator needle and plugger are selected. The needle tip should reach 3 to 5 mm of the apical terminus. You have to reach, the needle tip should reach 3 to 5 mm of the apical terminus passively. Apply sealer along the dentinal walls to fill the interface between gutta percha and dental walls. Place obturer needle loosely 3 to 5 mm short of the apex as warm gutta percha flows and fills the canal. So with the obturer needle, the heated GP which is melted, it is filling the canal, and this should be 3 to 5 mm above short of the apex. And back pressure, with back pressure, it pushes the needle out of the canal, because as the canal is getting filled from the apical end, your needle is being pushed outwards. Okay, so there is back pressure because of the heated GP which is being filling the canal at the apical terminus. Now use plugger to compact the GP. Pluggers are dipped in isopropyl alcohol or sealer to prevent sticking of the gutta percha. Now there are other carrier-based gutta percha solid core carrier technique like thermophil, which are available, and they are specially designed flexible steel, titanium, or plastic carriers coated with alpha phase gutta percha. I already told you alpha phase will be which is sticky, okay, which can flow. So this method of obturation was invented by Johnson in 1978, and it has become popular because of the simplicity and the accuracy of use. There are obturators which are available in size ranging from 20 to 140 and color coded to correspond to endodontic instruments. The carrier is not the primary cone for obturation. It acts as carrier and condenser for thermally plasticized gutta percha. So the technique is, see, this is the obturator. This is coated with GP. So the GP is melted and heated, and this acts as a carrier. Select obturator of the size and shape which fits passively at the working length. Verify by taking radiographs. Obturators is preheated in thermoprep oven for recommended time. So you have a thermoprep oven which is outside. You heat your obturator there. It becomes tacky, then you can put it in the canal. Canal is dried and lightly coated with sealer. Heated obturator is placed into the canal with a firm apical pressure. Working time is 8 to 10 seconds after removal of the obturator from the oven. Verify the fit of the obturation in radiograph while stabilizing the carrier with index finger. Cut the shaft with the orifice with inverted cone burr. So you can just cut the carrier with your inverted cone burr later on. Next, we have Gutta Flow. Gutta Flow is a novel filling system for root canals that combines two products in one, that is gutta percha in powder form with a particle size of less than 30 micrometers and the sealer. So Gutta Flow 2 is an advancement of the existing Gutta Flow material in capsules and has the same excellent material properties. So advantages is that the expansion, there is no time-consuming condensation which is required. Addition to gutta percha point and dentinal wall. There is no requirement of any additional sealer. Allows for excellent post-preparation, excellent flow properties. Solubility is virtually zero. Very good biocompatibility, excellent radiopacity, and protection from reinfections. So technique is, the largest master cone that will fit to the confirmed working length should be selected. Gutta flow can be placed directly into the root canal using the dispensing gun and the canal tip. Master cone should be coated with additional gutta flow, which can be done by applying the gutta flow directly from the dispensing gun. So you can ideally, you can fill the canal directly with the gun, dispensing gun and the canal tip, or you can coat your GP also with gutta flow directly from the dispensing gun. The master cone should be slowly inserted. Gutta flow dispenser can be used to backfill any additional space that may exist in the canal. So you have this dispenser like a gun, and in case there is any space inside the canal, that can be filled with the backfill. So to conclude, the clinical success of endodontic therapy depends on proper diagnosis, access preparation, complete chemo-mechanical preparation, and three-dimensional obturation of the root canal space. However, complete obliteration of the root canal space from canal orifice to apical constriction has been shown to be very critical to achieve success. The difficulties involved in totally obliterating the root canal space has led to innovations of variety of techniques and filling materials. So it is up to us to make judicious use of the various available techniques for endodontic irrigation, endodontic disinfection, and obturation. Hope this would have been useful. Thank you.